Welcome to the Hospital Medicine Unplugged podcast. In hospital medicine, the administration of blood products is, well, it's a common, often life-saving intervention. Yet few acute inpatient events trigger quite the same rapid, intense cascade of diagnostic workup and, frankly, resource mobilization as the sudden onset of fever during or shortly after a transfusion.
That alarm you mentioned is entirely justified, really. While most of these reactions thankfully turn out to be self-limited, the immediate clinical imperative always is to exclude the catastrophic diagnoses. We're talking about acute hemolytic transfusion reaction, AHTR, or perhaps a septic transfusion event. You just can't miss those.
Right.
So today, we're undertaking a deep dive into the evidence. We've synthesized current consensus guidelines, including some key ones published in the NEJM and JAMA, plus recent hemovigilance data. The goal is to provide a clear, evidence-based roadmap for diagnosing, managing aggressively when needed, and ultimately preventing these febrile non-hemolytic transfusion reactions, or FNHTRs.
Okay, and since our target audience today are fellow physicians, let's maybe move beyond just the textbook definition and really focus on the practical clinical implications of FNHTR. We know the key criteria: that temperature rise, at least 1 degree Celsius.
Right, leading to a core temp of 38 degrees Celsius or higher.
Or alternatively, the onset of rigors or chills. And critically, it has to occur within 4 hours of finishing the transfusion. But what's the major clinical challenge inherent in that definition, in the real world, on the wards?
The challenge lies entirely, I think, in those crucial exclusion criteria, defining it as non-hemolytic and non-septic. Well, that means the diagnosis is fundamentally one of exclusion. So in the heat of the moment, you have a patient who's now febrile, maybe even a bit hypotensive, confirming the absence of other identifiable causes. Is there an underlying infection brewing? Is there primary disease flaring up? Are there subtle signs of acute hemolysis starting? That takes time. And that necessary delay, the resource expenditure involved.
Yeah.
That's why FNHTR, despite being clinically benign in itself, imposes such a staggering resource burden.
Yeah, well, I want to focus on that resource burden for just a moment. FNHTRs, they're the most commonly reported reaction right now. And the rates seem stubbornly stuck around 0.1 to 0.3% of transfusions, even with current prevention methods like leukoreduction.
That's right, they haven't disappeared.
So if you think about the cost of that mandated workup, the stat labs pinging the lab techs, the repeat typing and cross-match, the cultures you have to draw from both the patient and the blood product.
Absolutely.
We're talking potentially thousands of dollars per event, and that's not even counting the nursing time tied up, the physician workload, all for a reaction that, in hindsight, probably would have resolved with just some acetaminophen.
The total systemic cost is, frankly, enormous. And it's driven purely by risk mitigation, as you said. We're essentially using a high-intensity, expensive workup to protect against extremely low incidence but potentially very high mortality events. We can't ethically skip that defensive workup. It's just not an option, which really makes prevention, particularly things like patient blood management and effective leukoreduction, the only true way to mitigate that associated resource cost.
Absolutely. And the classification really hinges on making that definitive differentiation early. So, okay, let's move to the pathophysiology, because understanding why this happens really provides the scientific rationale for our primary prevention strategies, like the leukoreduction you mentioned. We generally recognize two major distinct mechanistic pathways for FNHTR, correct?
That's right. Let's start with mechanism 1. This is the cytokine-mediated reaction. It's largely non-immune, really related more to the time the product spends sitting on the shelf. See, as blood products are stored, residual leukocytes still present in the unit even after filtering begin to break down. And as they break down, they release potent pro-inflammatory cytokines. We're talking specifically about things like interleukin-1, interleukin-6, interleukin-8, and good old tumor necrosis factor alpha.
Okay, and crucially, which products are primarily at risk for this kind of accumulation? Is there a difference between red cells and platelets?
Yes, a very important difference. Platelet units are the main offenders here. This is a critical distinction for hospital physicians to keep in mind. Platelets are stored at room temperature, which is, ideal for metabolic activity, and thus the rapid accumulation of these pyrogenic mediators. Plus, platelets are typically stored for up to 5 days, sometimes even 7 now in some places. Red cell units, on the other hand, are stored cold, so they accumulate these cytokines much less rapidly.
So by the end of a platelet unit's shelf life?
Exactly. By day 4 or 5, the recipient is essentially receiving a bolus infusion of these accumulated pyrogens, and that directly induces the fever and chills that are characteristic of the reaction.
Right, that makes sense. That accounts for product risk related to storage time and temperature. Now, what about the second pathway, the one that's purely immunologic? Recipient alloimmunization to donor leukocytes.
Right. This is where we see the classic antigen-antibody interaction. This pathway comes into play when the recipient has been previously sensitized. This usually happens through prior transfusions or maybe pregnancy. They've developed preformed anti-leukocyte antibodies. The most common targets are human leukocyte antigens, anti-HLA antibodies, or sometimes anti-granulocyte antibodies.
So when residual donor leukocytes, even a small number, because leukoreduction isn't perfect,
Right.
are transfused into that sensitized patient, what happens then?
The preformed recipient antibody immediately recognizes and attacks those residual donor white cells. That rapid antigen-antibody binding triggers a powerful immune cascade within the recipient. This interaction causes the endogenous release of pyrogens, meaning the patient generates their own fever-inducing substances in response. And that manifests clinically as fever and rigors.
Got it. And this distinction is crucial, I think, because while that pre-storage cytokine accumulation is the big issue primarily for platelets, this alloimmunization mechanism is highly relevant for both platelets and red cells, right? Because both can contain enough residual leukocytes to trigger a response in someone who's highly sensitized.
Precisely. Both mechanisms fundamentally rely on the presence of donor leukocytes, either alive and kicking, breaking down or releasing cytokines, or simply serving as a target antigen for pre-existing antibodies. And understanding this dual mechanism is really the cornerstone of the policy decision for universal leukoreduction. It's a single strategy that aims to disrupt both of those mechanistic pathways, reduce the source of cytokines, and reduce the target antigens.
Excellent explanation. Okay, now let's pivot to the clinical presentation. So the patient is febrile on the floor. What objective clinical clues should make us strongly suspect that this might just be the benign FNHTR, allowing us eventually maybe to stand down the full alert?
Well, the typical FNHTR presentation is usually moderate. The fever is acute, yes, onset often within the first hour or two of starting the transfusion, sometimes a bit later, but within that 4-hour window. Importantly, it's often self-limited. It doesn't usually progress rapidly to very high temperatures, often stabilizes under 39 degrees Celsius. The associated chills or rigors are definitely present, can be uncomfortable for the patient, but are usually manageable with simple comfort measures.
What stands out to you as the most critical negative finding clinically? What are you looking for that isn't there?
The absolute absence of any signs of organ system compromise. That's key. We should see no evidence of overt hemolysis. So, no new slank or back pain suggesting kidney involvement, no dark urine indicating hemoglobinuria. Also, crucially, no acute drop in blood pressure signaling shock, and no new respiratory distress like you see with TRALI or TACO. If the patient is hemodynamically stable, oxygenating well, and the symptoms are really limited to just that fever and maybe some chills, well, then you've kind of earned the time to execute this standardized workup calmly, methodically.
Okay, so let's systematically review the essential differential diagnoses that force our hand, the ones that require immediate high-intensity intervention. When fever and rigors occur, we absolutely must first and foremost exclude the lethal possibilities.
Right. Starting with AHTR, acute hemolytic transfusion reaction. This is often tragically the result of a clerical error leading to ABO incompatibility. The fever here is frequently accompanied by profound systemic symptoms. We're talking severe hypotension, often refractory to initial fluid boluses, intense back or flank pain resulting from renal injury or complement activation, and patients almost universally report this terrifying feeling of impending doom. If you suspect AHTR even slightly, the transfusion must stop and resuscitation must start immediately, no delay.
Absolutely critical. Next up, the septic transfusion reaction. This one demands aggressive empiric antibiotics, especially considering, rising concerns over resistant organisms.
Yes, septic reactions due to bacterial contamination. They're typically caused by organisms that can either survive or even thrive in blood storage conditions. For platelets, stored at room temp, it's often skin flora, think coagulus-negative staph, or sometimes even staph or ECS. For red cells stored cold, we worry more about psychrophilic, cold-loving organisms like Yersinia enterocolytica, though thankfully that's rarer now with better screening. The clinical hallmark here is usually a rapid onset high-grade fever, often spiking above 39 degrees Celsius. It's associated with severe, teeth-chattering rigors. And you'll often see evidence of a systemic inflammatory response syndrome, possibly progressing rapidly to frank septic shock and acute organ dysfunction. This is a true emergency.
Okay. And the hospital physician must also immediately consider acute pulmonary complications, specifically differentiating transfusion-related acute lung injury, TRALI, from transfusion-associated circulatory overload, or TACO. This is often where the bedside assessment gets most challenging, I find, because both can present with acute hypoxemia.
It's incredibly challenging, and the distinction is vital because the primary treatment is fundamentally opposed, right? Diuresis for TACO versus supportive respiratory care, maybe even fluids, for TRALI. TRALI is essentially non-cardiogenic pulmonary edema. It's typically immune-mediated, often by anti-HLA or sometimes anti-HLA antibodies present in the donor's plasma that activate the recipient's neutrophils in the lungs. It classically presents with acute hypoxemia, new bilateral infiltrates on chest imaging, usually within 1 to 6 hours of the transfusion.
Yeah.
And crucially, there's usually no clear evidence of volume overload. If you could measure it, the pulmonary capillary wedge pressure would be normal.
Right, non-cardiogenic. And TACO, conversely, is purely hemodynamic, essentially fluid overload.
It's exactly. TACO is hydrostatic edema, simply too much volume, too fast, for the patient's cardiovascular system to handle. It manifests as respiratory distress, often with marked hypertension initially, not hypotension, and the classic signs of volume overload, JVD, peripheral edema, maybe crackles on exam. Particularly common in patients with pre-existing cardiac or renal dysfunction. Clinically, a clearly positive fluid balance leading up to the reaction is highly suggestive. If the picture is still ambiguous, bedside tools can help, using point-of-care ultrasound, POCUS, to look at IVC collapsibility, or rapidly measuring a BNP level, which is often significantly elevated in TACO and typically normal or only mildly elevated in TRALI, can really help differentiate the two and guide your immediate therapy.
That use of BNP to help differentiate TRALI from TACO is a really powerful adjunct, definitely something that wasn't as commonly utilized, say, a decade ago. It can be very helpful in sorting things out quickly. Okay, finally, in the differential, we can't forget the non-transfusion-related fever sources, right? The patient might just be spiking for another reason.
Never forget the basics. The most common confounding diagnosis is simply an underlying infection that chose that moment to declare itself. Did the patient spike a fever because they got the transfusion? Or did they spike the fever because they have a developing UTI or evolving pneumonia that was brewing anyway? A thorough medication history is also essential thinking about drug-induced fever, especially with newly started antibiotics. We're considering hypersensitivity syndromes. And lastly, just to be complete, we should mention transfusion-associated graft versus host disease, TAGVHD. It's rare, presents days to weeks later, not acutely, with fever, rash, liver dysfunction, pancytopenia. Really only relevant in the specific context of severely immunocompromised patients receiving non-irradiated cellular products, not typically part of the immediate febrile reaction differential.
Got it.
Okay, let's move to the immediate action plan. This needs to be almost muscle memory for every hospital medicine resident, every nurse on the floor. When that reaction is suspected, call comes in fever during transfusion. What are the non-negotiable first bedside steps? Okay, the first 3 steps are simultaneous and absolutely non-negotiable. 1, stop the transfusion immediately, clamp the line. 2, maintain IV access, but critically, disconnect the blood tubing completely. Use a completely new set of tubing and flush the IV line with normal saline only. You want to ensure absolutely no residual product enters the patient. And 3, perform an immediate meticulous clerical recheck right there at the bedside. Match the blood product tag against the patient's wristband. Every single identifier name, MRN, blood type, unit number, this step must verify everything. Failure here is the leading preventable cause of catastrophic AHTR.
That clerical check is such a crucial safety step. It literally buys the team seconds, maybe minutes before launching into the formal workup and could prevent a disaster. Okay, so once that's done, transfusion stopped, line secured, ID checked, we notify the blood bank and assess the patient's hemodynamics, right?
Correct. The moment you notify the transfusion service or the blood bank, the institution's hemovigilance protocol should kick in. They'll want the unit back. They'll start their own processes. Simultaneously, the physician at the bedside needs to do a rapid assessment, looking for those high-risk signs. Is the patient hypotensive? Are they tachycardic? Is their oxygen saturation dropping? Is their mental status changing? The severity of these initial signs and symptoms really dictates the urgency and speed of the subsequent laboratory workup.
Right. So let's detail that essential laboratory workup. The panel necessary to definitively exclude the life-threatening diagnoses. This should really be standardized across all suspected reactions, big or small.
Absolutely. The essential panel is designed specifically to detect hemolysis and potential bacterial contamination. We must collect fresh blood samples from the patient and retrieve the residual transfused product bag with its tubing still attached. Send both down to the lab stat. What are we ordering? First, a repeat ABOR typing and cross-match on both a post-reaction patient sample and a segment from the product bag. Second, a direct antiglobulin test, the DAT, sometimes called the Coombs test, on the patient's sample to check for antibody coating of their red cells. And third, analysis of the patient's plasma and urine for free hemoglobin. Visible pink plasma or red urine is a huge red flag for acute intravascular hemolysis.
Okay, ABOR D8, free hemoglobin. We also need to assess general markers of red cell destruction, right?
Absolutely. A complete blood count looking for an acute drop in hemoglobin or platelet changes, and then specifically the markers of hemolysis. LDH will be elevated, haptoglobin, which binds free hemoglobin, will be consumed and rapidly drop, and bilirubin, particularly the indirect traction, will rise, though maybe slightly later. Beyond hemolysis, the definitive exclusion of a septic reaction hinges on cultures. This is non-negotiable. We must obtain blood cultures from both the patient and from the residual transfused product itself. The blood bank usually handles the product culture. Finding the exact same organism, whether it's staph or E. coli or something else in both the patient's bloodstream and the bag, confirms a septic transfusion reaction. It also allows the blood bank to trace the contamination source, potentially preventing other patients from receiving contaminated units.
That matching culture is key evidence. Okay, so let's say that initial workup, the clerical check is perfect, the DAT is negative, the plasma and urine are clear, no free hemoglobin, the hemolysis labs are unremarkable, and importantly, the patient is hemodynamically stable, maybe just that fever and some mild chills. Now we're likely in the realm of uncomplicated FNHTR. What is the evidence-based supportive management for these majority cases?
Right. If you've cleared those initial hurdles, management becomes much simpler. Supportive care is the absolute mainstay. Antipyretics, primarily acetaminophen, are given to relieve the fever and the rigors, improve patient comfort. We continue monitoring vital signs, maybe for a few more hours, until the patient's symptoms have clearly resolved and they're back to their baseline. And crucially, unless there is a compelling clinical reason otherwise, like overt signs of sepsis developing despite negative initial labs, or maybe high suggesting an allergic component, or persistent instability, no other specific treatments are typically required for straightforward FNHTR.
Let's explicitly state then which interventions are generally unnecessary for uncomplicated FNHTR, because these often get ordered reflexively and can add to clinical inertia, resource waste, maybe even side effects.
Good point. Unnecessary treatments include empiric broad-spectrum antibiotics. Those should absolutely be reserved for cases where there's genuine clinical suspicion of sepsis or if the patient becomes unstable. Steroids are also not indicated for FNHTR. There's no role for them here. And antihistamines, like diphenhydramine, also not helpful, as FNHTR isn't primarily a histamine-mediated allergic reaction. Using these agents in simple FNHTR is unwarranted and, as you said, potentially masks something more serious or causes side effects like sedation. Furthermore, if the patient is stable, the workup is negative for serious causes, hospital admission solely for the FNHTR itself is generally not indicated. They can often complete their surveillance period in the current setting, maybe the ED or observation unit, and be discharged if they meet all other criteria for discharge.
That's a really important point about avoiding unnecessary admissions. Okay, now we absolutely must transition to the management of the severe reactions. If that fever spikes high, say above 39 degrees Celsius, or if the patient is hypotensive, has severe uncontrollable rigors, or shows any signs of acute organ dysfunction, respiratory distress, altered mental status, poor urine output, what's the protocol for escalating care about?
Right, this scenario immediately moves the situation out of the realm of suspected FNHTR and into presumptive sepsis, or AHTR, or maybe TRALI. This demands immediate high-intensity resource allocation. The patient requires intensive monitoring, often warranting transfer to an ICU setting. For hypotension, aggressive intravenous fluid resuscitation must start immediately. We're usually talking large volumes of isotonic fluids, crystalloids like normal saline or lactated ringers, often starting with a 30 milliliters per kilogram bolus within the first hour or so, guided by response. If shock persists despite adequate fluid resuscitation, we move rapidly to vasopressor support. Norepinephrine is typically the first-line agent.
Okay, aggressive fluids, pressors if needed. And if septic reaction is still high on the differential, even with initial negative gram stain, the clock is ticking for antibiotics, right?
Absolutely. If sepsis is suspected clinically based on high fever, rigors, instability, empiric broad-spectrum antibiotics must be initiated promptly. The goal is ideally within the first hour of recognizing septic shock or severe sepsis, even while waiting for those crucial culture results from both the patient and the product. A typical empiric regimen might include something like cefepime or piperacillin tetamoxalatam, depending on local hospital resistance patterns and patient risk factors. Often coupled with vancomycin to cover MRSA, especially if platelet contamination is suspected.
Got it. Broad coverage. Fast. Now, turning specifically to acute hemolytic transfusion reactions, AHTR. We know the major life-threatening complication there is acute kidney injury. It happens from tubular obstruction by free hemoglobin casts and also immune complex deposition. What's the key management strategy to mitigate that renal damage?
The immediate priority is maintaining renal perfusion and maximizing urine flow to try and wash out the nephrotoxic pigment and debris. You must consult the renal team immediately. Get them involved early. Management centers on aggressive intravenous hydration with isotonic fluids, aiming for a robust urine output. The target is usually greater than 0.5 to 1 milliliter per kilogram per hour. Monitor urine output closely.
What about the historical debate around using forced diuresis or urine alkalinization? Is there still a role for mannitol or bicarbonate? That's a good question. Historically, yes, there was a theoretical rationale. Mannitol to induce an osmotic diuresis, and sodium bicarbonate to alkalinize the urine, which theoretically makes hemoglobin less likely to precipitate in the tubules. However, recent evidence supporting these interventions is actually quite mixed, and the absolute priority is ensuring adequate intravascular volume first. Volume status is paramount. So the focus is first on aggressive volume resuscitation with isotonic fluids. If urine output remains poor despite demonstrating adequate volume resuscitation, maybe guided by CVP or other markers, then cautious use of loop diuretics like furosemide or perhaps mannitol might be considered by the consulting nephrologist, but aggressively pursuing diuresis or alkalinity in a volume-depleted patient is definitely dangerous and should be avoided. Fluid first.
Makes sense. Volume first. And the lethal electrolyte abnormality we absolutely must watch out for in massive hemolysis. Hyperkalemia. Definitely hyperkalemia. Massive acute intravascular hemolysis rips open red blood cells, releasing large amounts of intracellular potassium into the circulation. This can rapidly lead to severe hyperkalemia, causing life-threatening ventricular dysrhythmias, including VFib and even a systole. So intensive monitoring of serum potassium levels like every few hours initially is absolutely mandatory. And you need to be ready for immediate treatment if it starts rising rapidly, using standard hyperkalemia therapies like intravenous insulin and glucose, calcium gluconate for cardiac membrane stabilization, possibly beta agonists, loop diuretics if kidney function allows, or potassium binding agents.
Critical point. Okay, let's shift our focus now towards prevention. This is really where system-level changes can have the greatest impact on reducing the overall incidence of FNHTR and, importantly, its associated costs and workup burdens. What remains the gold standard primary prevention strategy?
Without a doubt, universal leukoreduction of blood components. It is the single most important and effective intervention we have. Just to recap the science we discussed earlier, it works on both pathways. It drastically reduces the number of leukocytes that can break down and release cytokines during storage, thereby mitigating mechanism 1, especially in platelets. And it significantly reduces the number of leukocytes carrying foreign antigens, thereby minimizing the target for alloimmunization in sensitized recipients, addressing mechanism 2. Standard leukoreduction filters reduce the white cell count to less than 5 million, often less than 1 million per unit. This essentially neuters the product's capacity to trigger these common febrile reactions. Consensus guidelines universally endorse this as standard practice across the board for cellular components.
Right, universal leukoreduction is key, but relying solely on modifying the component isn't enough, is it? The other major pillar of prevention has to be patient blood management, or PBM.
Absolutely. PBM programs address the root cause, unnecessary exposure to blood products in the first place. By rigorously educating providers and adhering to restrictive transfusion practices, for example, sticking strictly to evidence-based hemoglobin thresholds, like less than 7 to 8 grams per deciliter for most stable hospitalized adults, or maybe less than 8. For those with known stable cardiovascular disease, we minimize the total number of units transfused across the hospital system. This is really basic epidemiology applied at the bedside. Fewer transfusions mean fewer opportunities for adverse events, including FNHTR, but also the more serious ones, period.
Fewer transfusions, fewer reactions, makes perfect sense. Now, let's tackle the pre-medication controversy head-on. Despite what seems like pretty robust evidence, many institutions, or perhaps individual habits, still lead to habitual ordering of acetaminophen and Ondor and antihistamines for patients receiving transfusions, especially if they've had a prior FNHTR documented. As experts reviewing the literature, What does the definitive evidence, thinking about high-level sources like Cochrane reviews, actually say about the routine use of pre-medication for preventing FNHTR?
The evidence is remarkably clear on this, and honestly, this is a critical takeaway point for our listeners, a practice change opportunity. High-quality evidence, including systematic reviews, does not support the routine use of pharmacologic pre-medication, either acetaminophen or antihistamines, for the primary prevention of FNHTR. Their efficacy for prevention is simply unproven in well-controlled studies.
Okay, so why do they fail mechanistically? It seems intuitive if a patient is developing a fever from cytokine release, why wouldn't an antipyretic like acetaminophen help prevent it before it starts?
It's a good question, but the pathophysiology is fundamentally different from, say, a typical inflammatory fever, where prostaglandins are the main driver centrally. Acetaminophen works primarily by inhibiting prostaglandin synthesis in the central nervous system. In the cytokine-mediated FNHTR, especially with platelets, you are directly transfusing preformed pyrogenic cytokines. The horse is already out of the barn, so to speak. While acetaminophen can certainly treat the resulting fever symptomatically after it develops, it doesn't prevent the underlying immunologic event or the effect of those preformed cytokines hitting the bloodstream. And furthermore, antihistamines are entirely ineffective because, as we discussed, FNHTR is generally not a histamine-mediated allergic reaction. There's no mast cell degranulation involved. The danger of routine premedication is really twofold. One, it provides a false sense of security. It might blunt the initial fever spike, potentially masking the early, crucial signs of a much more serious reaction like AHTR or sepsis, delaying recognition and treatment. And two, it adds unnecessary medication exposure, potential side effects, and cost.
Okay, so the bottom line is, pre-medication should likely be reserved only for highly select cases, perhaps those rare patients with a documented history of multiple severe recurrent FNHTRs despite receiving leukoreduced products. But it should absolutely not be standard protocol for everyone, or even everyone with a history of one mild reaction.
That is the strong consensus recommendation based on current evidence. Our energy, our focus, must be spent ensuring compliance with universal leukoreduction, implementing robust PBM protocols to avoid unnecessary transfusions altogether, and reinforcing meticulous adherence to strict protocols for patient and product identification at the bedside. That last part, reminding ourselves constantly about the clerical checks, is paramount because the AHTR that results from a simple identification error is almost entirely preventable.
Well said. Okay, let's conclude our discussion by reviewing the prognosis associated with these reactions and the necessary systemic monitoring post-transfusion, starting with the overwhelmingly favorable prognosis for uncomplicated FNHTR.
Yes. Thankfully, the prognosis for FNHTR itself is excellent. These are fundamentally self-limiting events. The vast majority of patients recover completely with just simple supportive care, usually within a matter of hours. Crucially, FNHTRs do not lead to long-term sequelae. They don't increase mortality. They don't significantly prolong hospital stays once the initial workup is negative. The system-level burden is acute and significant, yes, but the ultimate patient outcome is generally very favorable. The risk of recurrence is also relatively low, especially with current leukoreduction practices.
Okay, reassuring for FNHTR. Conversely, though, the prognosis for the severe reactions we discussed, AHTR, sepsis, TRALI, demands our continued respect and vigilance.
Absolutely. AHTR still carries a significant mortality risk, historically cited anywhere from 8% up to even 44% in some older series, heavily influenced by the severity of the reaction and the degree of acute kidney injury sustained. TRALI, while extremely morbid in the acute phase, requiring ICU care and often mechanical ventilation, is generally reversible if managed appropriately. Most patients, if given aggressive supportive respiratory care, recover without permanent lung damage, usually within 24 to 96 hours, but it's a very serious acute event. Septic reactions also carry high mortality if not recognized and treated rapidly with antibiotics and support.
Given these risks, both immediate and potential delayed reactions, what are the current standards or best practices for continuous monitoring, especially after a suspected reaction has occurred, even if it seems mild initially?
Continuous monitoring is essential. Standard practice involves checking vital signs, temperature, blood pressure, heart rate, respiratory rate, and oxygen saturation periodically during the transfusion itself, often every 15-30 minutes initially, then maybe hourly. But critically, monitoring should absolutely be continued for some period after the transfusion is complete, and especially after any suspected reaction has occurred. How long? At least 4 hours is typical, but maybe even up to 24 hours post-transfusion might be warranted, especially in high-risk patients, or if the initial reaction was concerning, even if labs were negative. This continued vigilance is crucial for detecting delayed presentations, perhaps the onset of TACO hours later, or a delayed hemolytic reaction which can occur days later, or even just ensuring the FNHTR has fully resolved.
Right, vigilance doesn't stop when the bag is empty. And finally, let's touch on the role of institutional hemovigilance systems in improving overall quality and safety related to transfusions.
Hemovigilance is key. Reporting is mandatory, legally and ethically, for all suspected transfusion reactions, not just the severe ones. This data is vital. High-performing health systems increasingly utilize real-time digital hemovigilance systems. These are often integrated directly with the electronic health record, EHR. These systems can automatically flag potential reactions based on vital sign changes or lab results ordered post-transfusion. They can guide the clinician through the mandatory workup steps, ensure documentation, and crucially, feed aggregated, de-identified data back into institutional quality improvement mechanisms. This allows for rapid root cause analysis, particularly if trends emerge like a cluster of reactions suggesting a problem with a specific blood component batch, or identifying near misses related to clerical errors. This supports continuous patient safety improvement in a way that relying solely on delayed, manual reporting often fails to achieve.
That integration with the EHR for real-time surveillance and reporting sounds like a major step forward. So this entire deep dive has really reinforced for me the complexity surrounding post-transfusion fever. It's a common scenario, but the differential diagnosis demands exceptionally high clinical vigilance initially to rule out those immediate threats, AHTR and septic reactions primarily, which require that immediate, aggressive, protocol-driven intervention.
Exactly. And that once those initial safety hurdles are cleared, you've done the bedside check, you've set the labs, the DAT is negative, the free hemoglobin is negative, the cultures are pending, but the patient is stable, then we can often step back. We can recognize the likely self-limited nature of uncomplicated FNHTR, manage it appropriately with simple antipyretics like acetaminophen, provide reassurance, and importantly, avoid the unnecessary cascade of antibiotics, steroids, or prolonged observation if it's not warranted.
That roadmap seems clear and definitely evidence-based. Okay, as a final, perhaps provocative thought for our listeners to consider as they go back to their clinical practice, given the really substantial systemic cost imposed by the mandatory defensive workup required for every FNHTR, the lab tests, the nursing time, the potential delays in other care, the physician cognitive load, and considering the compelling data supporting restrictive transfusion practices through patient blood management. How much further can we, collaboratively as physicians, nurses, pharmacists, blood bankers, push the utilization and, importantly, the adherence to robust patient blood management programs? Can we get even better at eliminating truly unnecessary transfusions altogether, thereby reducing not only the incidence of these benign FNHTR reactions, but also the immense associated resource costs that continue to plague our hospital budgets?
That is absolutely the essential quality improvement focus moving forward, I believe. Every single unit of blood product avoided through appropriate PBM is not only a risk averted for that patient risk of FNHTR, yes, but also infection, alloimmunization, TRALI, TACO, but it's also a significant cost save for the healthcare system. It's a win-win.
Indeed. A crucial area for continued focus, we encourage all of our listeners to learn about and champion robust PBM initiatives within their own hospitals and practices. Thank you for joining us for this deep dive into the diagnosis and management of febrile transfusion reactions.